Usually when we talk about medical diagnostics, there's this really comforting expectation of precision. Like it feels like engineering, you know?
Right, yeah. It's very binary.
Exactly. You take your blood pressure, you get two distinct numbers, you check your temperature, and you read a decimal point on a thermometer. It's clean, it's visible, and it's easily categorized.
You either have a fever or you don't. The numbers tell you exactly where you stand.
Yeah, but then you step into the world of sexual health and cosmetic gynecology, and suddenly you're trying to use a standard ruler to measure a sunset.
That's a really good way to put it. It's incredibly murky.
Right. Because how do you objectively quantify human pleasure? Like, how do you put a numerical value on intimacy? So today we are taking a deep dive into this fascinating intersection of subjective human emotion and rigid scientific metrics.
It really is a fascinating space.
It is. We're looking at the rapidly growing yet highly debated field of cosmetic gynecology specifically, G-spot augmentation. And our mission for this deep dive is to figure out exactly how clinicians measure the unmeasurable.
Right, because before they can even treat a patient, they have to establish a baseline.
Exactly. We're focusing on how doctors use these complex psychosexual evaluation tools, like the Female Sexual Function Index, to set that baseline for patient expectations before they ever even touch a needle.
Yeah, we're inviting you into this clinical space where physical medical intervention meets deeply personal psychological expectations in a very, very delicate balancing act.
It really is. And to unpack this balancing act, we have this massive stack of sources in front of us. We're pulling from clinical case reports, guidelines from the American College of Obstetricians and Gynecologists, specialized practitioner blogs from cosmetic surgeons, and some incredibly detailed breakdowns of psychometric tools.
There's a lot of data to sift through.
Tons of it. But before we can understand how doctors evaluate a patient for this procedure, we need to know what the procedure actually is. So what exactly is a G-spot augmentation?
So in clinical settings, it's commonly referred to as the G-shot. Fundamentally, it's an outpatient, minimally invasive cosmetic procedure. The clinician injects a biocompatible filler directly into the anterior vaginal wall. And yeah, the fillers vary, but they're usually hyaluronic acid, medical-grade collagen, or sometimes even a patient's own purified fat.
Wow, okay. And geographically speaking, we're talking about an area roughly 1 to 3 inches inside the vaginal canal, right?
Yes, exactly.
So what's the actual goal of injecting filler right there?
Well, the goal is to temporarily increase the volume and the physical prominence of this highly vascularized, nerve-dense area. The underlying anatomical theory is that by adding physical volume, you increase the surface contact and friction during intimacy.
Got it. So more surface area.
Right. That increased friction theoretically heightens sensitivity and could improve a woman's ability to achieve a vaginal orgasm.
Okay. But you use the word temporarily. So this is not a permanent structural change to the body.
No, not at all.
Mm.
Depending on the specific type of filler used, the body naturally absorbs the material over time.
Like how lip fillers dissolve.
Exactly like that. The effects typically last anywhere from 3 to 6 months. Meaning, it requires maintenance if the patient wants to keep that added volume.
Okay, we really have to address the medical controversy surrounding this because our sources present a very sharp divide. And we're going to look at both sides of that divide impartially for you.
It's definitely a polarized topic.
Yeah, so on one hand, you have the American College of Obstetricians and Gynecologists, or ACOG. They issued Committee Opinion Number 378, which gives a very clear warning that procedures like G-spot amplification are not medically indicated.
Right, they're very firm on that.
They state there is a lack of long-term safety and efficacy data, and they highlight potential risks. Things like altered sensation, painful intercourse, which they clinically call dyspareunia adhesions, and scarring.
Yeah, and that really represents the institutional conservative medical stance. I mean, major medical bodies look for large-scale, long-term, randomized controlled trials before endorsing a procedure.
Which makes sense.
It does. But cosmetic gynecology, being relatively new and highly subjective, simply lacks that robust, decades-long data.
Right. But then on the other side of the spectrum, you have the clinical sources. These are the surgeons actually performing these procedures daily.
And their perspective is very different.
Completely different. They report very high patient satisfaction rates, pointing to post-operative patient surveys that show boosted self-esteem and significantly enhanced sexual satisfaction.
Yeah, they see the immediate positive impact on their specific patients.
But I noticed that even the most enthusiastic clinical sources put up a massive disclaimer. Like, they explicitly state that this procedure cannot treat sexual dysfunctions that are psychological or hormonal in nature.
Absolutely not. It's a physical intervention only.
And it absolutely does not guarantee an enhanced experience. It kind of sounds like putting premium high grip tires on a sports car. Like, it might improve the handling and the ride, but if the engine itself is failing or there's no fuel in the tank, those new tires aren't going to make the car run.
That's a perfect analogy. You're changing the physical interface with the road, but you aren't touching the internal mechanics of the vehicle.
Right.
If the underlying mechanism isn't working, the surface-level intervention is basically useless.
So if that's the case, it puts a massive burden on the doctor. I mean, given the physical limitations of the procedure and given the stark warnings from bodies like ACOG, how does a cosmetic surgeon possibly figure out if a patient is a suitable candidate?
It's tricky.
How do they check the engine before they sell the tires?
Well, because the physical intervention cannot fix a psychological or hormonal issue, responsible clinicians must establish a rigorous psychological and functional baseline before they proceed.
They need to know exactly what they're working with.
Exactly. They have to map out exactly where the patient is starting from.
And they do that using psychosexual evaluation tools. The absolute gold standard mentioned across our sources is the Female Sexual Function Index, or the FSFI.
Yes, the FSFI is everywhere in the literature.
The mechanics of this test are wild. What does taking the FSFI actually look like for a patient?
So it was created back in 2000 by Raymond Rosen and a team of experts, and it's since become globally recognized. It's been translated into over 20 languages with thousands of citations.
Oh, wow. So it's heavily validated.
Extremely. For the patient, it's a 19-item self-report questionnaire. It basically evaluates their sexual function over the past 4 weeks by breaking female sexuality down to 6 distinct domains:
Now those domains are...
desire, arousal, lubrication, orgasm, satisfaction, and pain.
Okay, and the sources mentioned that patients answer these 19 questions using a 5-point Likert scale. That sounds like something straight out of a psychology textbook. What does a Likert scale actually look like in practice?
It's actually something you've probably filled out 100 times on customer surveys without knowing the name.
Oh, really? Like the strongly agree to strongly disagree stuff?
Exactly. Instead of a simple yes or no, a Likert scale gives you a range of options to measure intensity or frequency. So a question about arousal might offer answers ranging from 1, meaning almost never or never, up to 5, meaning almost always or always.
Okay, so it allows for nuance rather than just binary answers.
Right, it captures the gray areas.
Where it gets incredibly interesting to me is the math. Like, you don't just add up the 19 numbers from that 1 to 5 scale and give the patient a grade. The scoring system is highly specific, and it uses weighted multipliers.
The multipliers are fascinating.
They really are. For example, the scores for the desire domain are multiplied by 0.6, but the scores for arousal and lubrication are only multiplied by 0.3, and then orgasm, satisfaction, and pain are multiplied by 0.4. Why go through the trouble of weighting the scores so differently?
Well, the weighting is where the clinical genius of the test really shines, because it reflects the physiological and psychological philosophy of how human intimacy actually works.
So if I can try an analogy here, is it kind of like the ignition of a car? Like, if you don't turn the key in the ignition, which is desire, it really doesn't matter how well the pistons are lubricated or how ready the engine is to run.
Exactly.
The test weights the key turn the heaviest because it's the necessary gateway to everything else.
That captures the mechanism perfectly. Desire is the cognitive emotional spark. It's highly complex. I mean, it involves neurochemistry, relationship dynamics, stress levels, all of it.
So it's heavily psychological.
Right. And if that spark is completely missing, the downstream physical responses like arousal and lubrication often just will not trigger.
That makes total sense.
So by weighting desire with a 0.6 multiplier, the FSFI acknowledges that a primary lack of interest is a much heavier indicator of overall systemic dysfunction than, say, a temporary physical issue with lubrication.
Which could just be like a side effect of taking cold medication or something.
Exactly. It doesn't necessarily mean the whole system is broken.
Okay, so once the doctor applies all these multipliers to the patient's survey, they get a total score ranging from 2.0 to 36.0. What's the magic number they're actually looking for?
The globally recognized clinical cutoff for identifying female sexual dysfunction is 26.55.
26.55, very specific.
Extremely. If a patient scores below that, they are flagged for potential dysfunction. Though, It is worth noting that context and culture matter deeply here.
Oh, how so?
Well, one of our sources, a Thai study, culturally adapted that cutoff to 23.1 for their specific demographic.
Oh, wow. That's a pretty significant drop.
It is. They recognize that cultural norms around discussing intimacy can influence self-reported scores. Some cultures might naturally score lower just because they're less comfortable talking about it.
Right, they might downplay their answers. Okay, so if the total score is, okay, say they get a 28, but their desire score specifically is rock bottom, does the test flag that discrepancy?
It absolutely does, and that's why breaking it down into domains is so crucial. A score of 5 or lower, specifically on the desire domain, helps clinicians identify hypoactive sexual desire disorder, or HSDD.
Okay, so it isolates the exact problem.
Right, it allows the doctor to see the exact landscape of the issue. A patient might have great desire and arousal, but score terribly in the pain domain. The doctor instantly knows they need to investigate a physical cause of pain, not a psychological lack of interest.
This complex math is fascinating, but it also feels like a minefield. I mean, evaluating sexual health this way must be full of potential statistical traps.
It is. It really is.
Yeah.
Researchers and clinicians often stumble into a very famous trap in the SSFI known as the zero problem.
The zero problem. Because 12 of the 19 items on the questionnaire have a zero option, right? Which stands for no sexual activity over the past 4 weeks.
Yes.
Think about how absurd this could be in practice. Like, if you're a completely healthy person, but you've been traveling for a month on a grueling business trip, you haven't been sexually active. A researcher crunching this data might accidentally classify you as having medical dysfunction simply because you were busy.
They absolutely would if they aren't careful. If a clinician blindly plugs in zeros for a patient who just hasn't been active, it artificially tanks their total score.
It makes them look highly dysfunctional on paper.
Exactly.
Mm-hmm.
But no activity does not inherently mean dysfunction. A woman might be single, she might be postpartum, or maybe she's just taking a break.
Right.
If this zero problem isn't controlled for in studies, it artificially inflates the rates of sexual dysfunction in the general population.
Which means the FSFI alone cannot clinically diagnose a dysfunction.
No, it can't. Medically speaking, according to the diagnostic criteria, the DSM-5-TR, a low score is only a true dysfunction if it causes the patient significant personal distress.
Ah, okay. So distress is the key factor.
Yes. If a patient scores a 20, but they are perfectly happy and unbothered by their sex life, they do not have a medical dysfunction. They just have a low score.
Okay, but how do you measure distress? You can't just ask, hey, are you distressed?
Well, you pair the FSFI with distress measures, like the Female Sexual Distress Scale.
Wait, FSDS.
Right.
Yeah.
It's another validated questionnaire that specifically asks how often the patient feels guilty, frustrated, or stressed about their sex life.
Okay, so if we bring this back to the cosmetic surgeon's office, a patient walks in wanting the G-shot. The doctor gives them the FSFI to measure function and a distress scale to measure frustration. But since we're talking about a cosmetic procedure, the psychological screening has to go deeper than just sexual function, right?
Oh, definitely. Clinicians also have to screen for body dysmorphic disorder, or BDD.
Right, which is much more than just not liking how you look.
Exactly. This isn't just regular insecurity about your body. BDD is a severe psychological condition characterized by an obsessive, time-consuming focus on a perceived or slight physical defect.
So a cosmetic fix won't actually help them.
Never. A patient with BDD will never be satisfied with a cosmetic procedure because the defect they see is magnified by their brain, not their anatomy.
Our sources also mention tools like the Female Genital Self-Image Scale, the FGSIS. I assume that measures how the woman views her own anatomy.
It does, and it helps the doctor figure out if the patient's motivations are internal, meaning they're pursuing the procedure for their own comfort and satisfaction, or if their motivations are driven by external pressures.
External pressures like what?
Like a demanding partner, or maybe unrealistic expectations driven by pornography or media.
Let me play devil's advocate here for a second. If a patient is absolutely desperate to get this procedure, perhaps because of deep relationship insecurities, or they think this shot is a magic bullet to save their marriage, couldn't they just game the questionnaire?
You meant how?
Like, they know what the doctor wants to hear to approve the surgery. They could easily fake a positive genital self-image or downplay their distress on a piece of paper.
That's a fair challenge, and self-report tools always carry the vulnerability of patient deception. However, these tools aren't just simple magazine quizzes.
Okay, so they're a bit more sophisticated.
Very much so. The FSFI, for instance, is built with internal consistency checks. The questions are designed in a way that makes it difficult to fake a perfectly normal profile if you are genuinely struggling.
Give me an example of that.
So, if a patient claims perfect physiological arousal but terrible lubrication, the tool flags that physiological contradiction. It doesn't physically make sense.
Oh, interesting. So the test has tripwires built into it.
Exactly.
But even with tripwires, a highly motivated person could still potentially fool a piece of paper, right?
They could, and that's exactly why the questionnaire is never the final word. It's merely the baseline.
Right.
A skilled practitioner uses those scores to guide the clinical interview. They're looking for incongruities. If a patient scores perfectly on self-image, but exhibits extreme anxiety, avoidance, or distress during the physical exam, the doctor knows the paper score is a lie.
The numbers just guide the conversation, but the doctor is looking for the story behind the numbers. And our practitioner guides emphasize that if psychological concerns or BDD are suspected during that interview, the protocol is to immediately halt the process and refer the patient for psychological evaluation.
Yes, before ever considering the physical procedure. You cannot solve a psychological fixation with hyaluronic acid.
Right. Okay, let's assume the patient navigates this rigorous psychological screening perfectly. Their motivations are sound, they do not have BDD, they have highly realistic expectations, and the doctor successfully establishes their FSFI baseline. What happens when they actually perform the procedure? Do the postoperative metrics match the preoperative hopes?
To answer that, we can look at the clinical outcomes highlighted in our sources. There's one really compelling case report that follows a 48-year-old perimenopausal woman. She presented with vulvovaginal atrophy, which was causing her significant discomfort and sexual dysfunction.
Okay, for those of us unfamiliar with the medical term, what exactly is vulvovaginal atrophy?
So, as women approach menopause, estrogen levels drop significantly. And estrogen is responsible for keeping vaginal tissues thick, elastic, and lubricated.
Oh, I see.
Yeah, so when those levels drop, the tissues can become thin, dry, and inflamed. That is vulvovaginal atrophy, and it can make intimacy incredibly painful.
So the treatment for this specific patient was a multi-layer approach using hyaluronic acid, or HA. But the source specifically mentions they use a combination of cross-linked and non-cross-linked HA. Why would a doctor use two different types of the exact same filler?
It comes down to how you want the filler to behave in the body once it's injected. Think of cross-linking, like adding molecular support beams to a structure.
Okay, support beams.
Right. Cross-linked hyaluronic acid is thicker. It holds its shape and stays in place longer, which provides the structural volume needed to physically enhance the targeted area.
And the non-cross-linked?
Non-cross-linked HA doesn't have those support beams. It just spreads out and acts purely as a hydrating agent. It pulls moisture into the thinning tissues to combat the dryness caused by the atrophy.
Oh, that's brilliant. So the doctor is simultaneously building structure and adding hydration. The results for this patient were measured using a short-form version of the FSFI, and they were striking.
They really were.
Her baseline score before the procedure was a 6.0, which is severe dysfunction. And at her 6-week follow-up, her score had jumped to a 24.0.
Wow. I mean, she essentially crossed the threshold entirely out of the severe dysfunction category. And the clinical photographs also document a marked physical improvement in tissue condition and hydration.
That's an impressive outcome for a single case report. But we also have broader comparative studies. One of our sources is a pilot study that compared using hyaluronic acid versus platelet-rich plasma, or PRP, for anterior vaginal wall augmentation.
PRP is a fascinating alternative to fillers.
Yeah, what is it?
Instead of injecting a synthetic filler, the clinician actually draws the patient's own blood, spins it down in a centrifuge to isolate the platelets, and re-injects that concentrated plasma right back into the tissue.
That sounds intense. How does injecting your own blood plasma actually enhance the tissue? What's the mechanism there?
Well, platelets are packed with growth factors. When you concentrate them and inject them into tissue, they signal the body to begin cellular repair.
Oh, so it's regenerative.
Exactly. They stimulate angiogenesis, which is the creation of new blood vessels, and they trigger collagen synthesis. So while HA provides immediate physical volumetric enhancement like a sponge holding water, PRP works by telling your own body to regenerate and rejuvenate the tissue over time.
Okay, so in this pilot study, both the HA group and the PRP group showed significant improvements in their post-operative FSFI scores. Did one actually perform better than the other?
The study found that HA showed a statistically greater short-term benefit in rapidly improving those FSFI scores. That's likely because the volumetric change with HA is instant. But both therapies were deemed safe and effective in that specific trial.
Okay, so the physical intervention, the new tires, can indeed improve the ride. But what if the infrastructure surrounding the area is weak? Does a filler even matter if the muscles around it are compromised? Let's talk about the pelvic floor because this totally shifts the focus away from injectables.
Oh, this is a crucial, often completely overlooked piece of the puzzle. One of our sources investigated the relationship between pelvic floor muscle strength, or PFM, and FSFI scores in women who are experiencing stress urinary incontinence.
And what did they find when they correlated that muscle strength with the sexual function index?
They found a highly significant correlation. Women with stronger pelvic floor muscles had significantly higher scores in the desire, arousal, and satisfaction domains of the FSFI.
I mean, I understand how stronger muscles might improve physical arousal or physical satisfaction, but how does a stronger pelvic floor increase a woman's psychological desire?
It's because the physiological mechanisms are deeply intertwined. A stronger, more toned pelvic floor means vastly better blood flow to the entire pelvic region. It means stronger involuntary muscle contractions during orgasm and potentially enhanced nerve response and sensitivity.
Okay.
When the physical body responds efficiently and pleasurably to stimuli, it creates a positive feedback loop to the brain. Knowing your body works well reduces anxiety, which in turn lowers psychological barriers and increases your baseline desire.
That makes perfect sense. This highlights the true multifactorial nature of human sexuality. Like you can inject cross-linked HA to change the physical landscape. You can add volume and hydration. But if the foundational structure of the pelvic floor is weak, or if the psychological distress we measured during the baseline evaluation is still lingering, you haven't actually solved the puzzle.
Which is exactly why the researchers in that study conclude that pelvic floor muscle training physical therapy should very often be the first strategy to improve female sexual function.
Long before a clinician ever reaches for a needle.
Exactly, or considers any surgical intervention.
Yeah.
You have to ensure the infrastructure is sound before you start making cosmetic alterations.
We've covered incredible ground today. We started with the physical mechanics and the stark controversies surrounding G-spot augmentation, balancing those institutional warnings from ACOG against the clinical success stories.
Yeah.
And then we dove into the deep, math-heavy world of the female sexual function index, unpacking why a single point of desire acts as the ignition key for the rest of the physical response.
Right. And we explored the absolute necessity of psychological baselining, how clinicians must navigate the zero problem to avoid bad data, screen for obsessive conditions like body dysmorphia, and ensure that a physical procedure isn't just being used as a band-aid for deep emotional distress.
Understanding this rigorous evaluation process really matters. I mean, it offers a clear window into how the modern healthcare system attempts to take deeply personal, entirely subjective human experiences and validate them by forcing them into objective, scorable metrics.
It really highlights the eternal tension in medicine. Clinicians are constantly trying to treat the physical body while simultaneously treating the incredibly complex mind that lives inside it.
Which brings me right back to where we started. Using a ruler to measure a sunset. It leaves me with a final lingering thought for you to mull over today. As we continue to standardize and strictly quantify sexual pleasure with indexes, Likert scales, weighted multipliers, and decimal points, do we risk medicalizing an experience that is inherently meant to be wild, subjective, and unquantifiable?
That's a deep question.
By putting a hard clinical number on intimacy, does it fundamentally change the way we actually experience it?
That is a philosophical question that both clinicians and patients are going to be navigating for a very long time.
Something to think about. Thanks for taking this deep dive with us.